So what is Tulsa, a focal treatment for prostate cancer? And no, it's not, in this case anyway, we're not referring to the city in Oklahoma where perhaps that's the only place where you could get this treatment. No, that's not the case at all. This is transurethral ablation or transurethral ultrasound ablation therapy, Tulsa, and that's the abbreviation. What is it and how does it work? Before we continue on what Tulsa is and the introduction to our next guest, I do want to inform you and even encourage you to go to our last episode with Dr. Arvind George. That's episode 117, where he gives you a very nice overview on focal therapies. Dr. Arvind George, of course, is one of the foremost experts on focal therapy from Johns Hopkins. So make sure to take a look at that. Today we have Dr. Xiaosong Meng, who is faculty at UT Southwestern Medical Center in the Department of Urology. Dr. Meng trained at NYU. He did his residency there, and he also obtained his PhD. He also played a key role in building the NYU prostate MRI and MRI US fusion targeted prostate biopsy database, which formed the basis for the multiple projects throughout his residency. Dr. Meng is an expert in focal therapy out of Texas, UT Southwestern. Particularly, he's an expert in Tulsa and also IRE, irreversible electroporation therapy, or IRE, which is not today, in 2024, is not yet approved for prostate cancer treatment, but it probably will be soon. Dr. Meng is one of the foremost experts in these types of focal therapies. We talked about different things as it relates to Tulsa. How does it work? Who's the right patient for it? Why would I choose, if I'm a patient, Tulsa, which is you treating the prostate cancer through the urethra, right? Not through the rectum, with a different type of focal therapy like HIFU. And why would I choose that versus, I don't know, cryoablation therapy or HIFU or IRE, let's say? So we have a very nice deep discussion on that. And what if the patient has a small prostate versus a large prostate? Is it beneficial if the patient has, for example, an enlarged prostate that affects their urinary function? Is it possible for them to get a 2-for-1, treat the cancer and treat the BPH? You're going to really enjoy this show with Dr. Meng on all things Tulsa for prostate cancer. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor.
September is Prostate Cancer Awareness Month, and the Dr. Geo Prostate Podcast is here to help you make informed decisions on your prostate journey. This month, our podcast sponsors are Focal One, the first robotic platform for precise prostate ablation using HIFU. Also sponsoring this month is Profound Medical, innovators of the Tulsa Pro, an advanced focal ablation treatment using the Tulsa procedure. Click the link in the description to learn more about our sponsors. Enjoy the podcast.
Welcome to the Dr. Geo Podcast. I am your host, Dr. Geo. Here to help you optimize your prostate health, figure out some answers as it relates to prostate cancer, testosterone, erections, and even how to live better with age. Today's guest, you know much about him from the intro, Dr. Xiaosong Meng. Xiaosong, thank you so much for being here today. Particularly before we started recording, you shared with me, great news that you are a new father again after today. Your wife gave birth, and here you are with me. Here you are with me doing this interview or this podcast conversation. So I appreciate it so much.
Of course, happy to be here, Dr. Geo. Certainly a nice podcast, and happy to join, part of your illustrious kind of panels of people who've been on here before.
Yeah. So my audience is rapidly growing, and they love focal therapies. I think they think, right? So since I'm a natural doctor, sort of like focal therapy falls under that umbrella. It's almost like this is a natural medicine for prostate cancer, right?
Mm-hmm.
At least that's how it's presented, or that's how they interpret it. And so I already have had numerous experts on focal therapy. Jim Weissock has spoken about cryo to some degree. So did Tanasia. Cianti talked about several. And then Arvin George, of course, talked about an overview of focal therapies, what's available, and how it works. With us today, you and I will talk about Tulsa. And so many people have asked me, hey, Tulsa, am I a candidate? Here's my thing. I don't play doctor through the internet, so I don't know. So, and we are not going to play doctor over the internet here, though we are real doctors. But I think we're going to give people some clarity as to what Tulsa is, who's the right candidate, and perhaps, who's not the right candidate for this treatment. So let's take it from the top and tell us, what is Tulsa? Take it as simple as you can.
Yeah, no, I think that's a great question. So Tulsa is not for the city in Oklahoma. It actually stands for Transurethral Ultrasound Ablation.
Mm-hmm.
Essentially, it's a form of ultrasound energy similar to HIFU,
Mm-hmm.
but the device is placed through the urethra. It ablates energy outwards from the urethra to the periphery of the prostate.
Mm-hmm.
And different from HIFU, which is kind of a focused ultrasound energy, Tulsa is a directional planar energy. So it basically fires out sheets of ultrasound waves, and the probe is on a robotic arm that's actually able to rotate 360 degrees within the prostate. So instead of like HIFU, where you're treating from outside in, you're treating from inside out, is kind of the best way I like to explain to patients about Tulsa.
And so similar to HIFU, except this is through the urethra.
Yep.
Some people off the top, right? They would think, all right, conversation is released to prostate cancer. And this is what I share with my medical colleagues at NYU, because I'm very interested into the psychology of things. I think mind-body connection is strong, of course, and these
Mm-hmm.
things. So I'm always thinking, all right, when they go see you guys, you're saying, well, the data says X, Y, and Z, and so far, this is what we have data. And I think many times patients care about that, but not as much, because this is an emotional situation. And we want to put that away and say, well, no, we're looking at this objectively. I don't think we should think that we should only look at it objectively. I think emotions do matter.
Mm-hmm.
As it relates to the C word, right?
Right.
And so some of these guys are listening to you and say, well, through my penis? Oh my God, I'd rather have something through my rectum and not through my penis. Of course, many of them have done cystoscopies, and they're saying, well, I thought it was that really bad, but it wasn't that bad. So maybe you could share with us the advantages from that one would get if they, let me take that back, because I know it is an individualized scenario, right? So some people, based on what they have, they might be a candidate for one type of
Mm-hmm.
focal treatment and not for another. But from a very basic perspective, what is the advantage of doing it from a transurethral approach versus transrectal?
Yeah, so I think that there's a few advantages to Tulsa. So I agree the transurethral approach is one. So it allows you to treat the anterior part of the prostate a little bit easier. You can treat about 3 centimeters from the urethra to the margin of kind of where the energy reaches, which allows you to really reach a good majority of the prostate.
Mm-hmm.
One of the challenges with HIFU, especially coming from the rectum up, you've got about 4 centimeter reach, including the rectal wall. So it's harder to treat the tumors kind of at the anterior part or the kind of the top part of the prostate.
The energy cannot get to the anterior part of the
Right.
prostate. So HIFU, and I'm sure I'll have other conversations more detail with others, can only treat but so much, maybe the peripheral section.
Yeah, so
primarily?
I think HIFU is really good for posterior prostate, peripheral zone prostate. You have to worry about the urethra being in the way. So if you have an anterior tumor, it becomes a little bit more challenging. It's certainly doable, but I think there are some technical challenges and kind of patient anatomic challenges that you have to work around.
Mm-hmm.
Tulsa, I think, allows us to treat anterior prostate easier. And the other really nice thing about Tulsa is it's done in the MRI machine. So this is done with the patient fully asleep. It's done under MRI guidance, and it's a closed loop feedback, meaning the robot uses energy or uses the temperature map of the prostate, which is generated by the MRI machine every 5 seconds, to take so basically it's saying, okay, this part of the prostate has reached the right temperature. And I'm going to move the robot arm and I'm going to continuously sweep through the prostate. So I think a few things. It gives you better feedback of where you're treating. Because it's done under MRI guidance, you can actually dynamically adjust your margins. You can say, okay, the prostate swelled a little bit here. I'm going to move my treatment just a little bit further out. Here's a nerve bundle. You can see the nerves better. You can see ejaculatory. So you're able to tailor your approach a little bit better. And finally, I think, it gives you a little bit more ability to treat men with kind of more issues. So oftentimes I'll treat guys with BPH, benign prostate hyperplasia, which is very, very common, as well as prostate cancer, because, they're already having some trouble urinating. I'm already being in there. I'm treating their prostate. I'm already going to, be going from the urethra to their cancer, which is usually or often on the periphery. So I'm already getting part of their transition zone. But I might as well just increase my boundaries and kind of treat their transition zone, so help them with their urination plus their cancer.
So potentially you can get a twofer here.
Yep. Yeah, and in Europe, they actually use this for enlarged prostates alone, which we don't do here. But certainly they
That's
do.
what I was going to ask,
BPH.
Yeah, I was going to ask. It sounds like you can use it. I mean, it's not approved perhaps to be used for BPH, and thank
So
God.
actually, it's approved for prostate ablation in general. There's not a prostate cancer specific. It's actually harder for companies to get prostate cancer specific indication. So it's for prostate tissue ablation. So you can use it for BPH plus cancer. I think the company is actually very interested in bringing this into the BPH space as well, because the number of patients is a lot, right? So
on one end, I'm like, great, this sounds great for BPH. On the other end, I'm like, another treatment for BPH that we choose?
There's already way too many.
I mean, I just had one of our NYU guys, a radiologist that does PAE, right? Peripheral arterial embolization. I had a whole lip guy. And it's like, Chris Kelly at NYU does aqua ablation.
Yep.
And it's like, and forget it, resume, and it just keeps going on. So on one hand, I'm like, great, another treatment for BPH. On the other hand, it's like, oh my God, you got to choose. So for prostate cancer, so the person who wants a focal therapy that also has BPH symptoms, urinary symptoms, and prostate cancer, that's like the ideal candidate.
I think it's a guy with kind of intermediate risk disease, right? So I still think that even though focal therapy, has
actually we'll go through the specifications on that, because I think that's very important. But in terms of symptoms and the fact that they have the right cancer for now, that where it's the right, Tulsa might be the right approach. That's the ideal candidate.
Yeah, I think so. And
not limited to that patient population, of course, but that's the ideal candidate. All right, so let's go there. I got a guy with a Gleason 9 in the anterior zone. And Dr. Meng, I know you're going to say, nope, two options, either remove your prostate or radiation and ADT. Right. But Dr. Meng, quality of life, I'm 52, quality of life is great. Look, can I do with this Gleason 9? We know through the PSMA scan and other images that there's nothing, everything is encapsulated. What I have is what I have. Hey, friends, help me welcome yet our next amazing sponsor, Profound Medical. They're the producers of Tulsa Pro, another focal ablation treatment. Profound Medical is at the forefront of revolutionizing prostate disease treatment with Transurethral Ultrasound Ablation, or Tulsa procedure. That's within the urethra. That's the tube that brings out your urine and semen. The treatment occurs through that urethra, not through the rectum. This incision-free approach targets and destroys prostate tissue from the inside out, aiming to reduce the risk of complications such as erectile dysfunction and incontinence, while ensuring that there is an effective oncological control with a swift return to daily life. By integrating real-time MRI with advanced robotics, Tulsa offers a highly customizable solution, precisely targeting the entire prostate gland or specific areas, setting a new standard in prostate care. To learn more about Profound Medical and Tulsa Pro, please go down to your show notes and click the link. Are they a candidate for Tulsa?
That's a great question. And that's probably a harder question that we need more data for. Often, I'll send a decipher, look at the molecular kind of characteristics of their tumor. I tend to shy away from treating guys with high-risk disease, and special, But occasionally a patient say, look, I'm not going to do anything else, right? It's either this or, I'm not going to do surgery. I'm not going to do radiation. I'm just going to do some sort of focal. So I'm going to, so then I think, okay, well, if you're not going to do anything else, we talk about this with our men, right? So a lot of times physicians, we say, okay, we're trying to prioritize cancer control. But for a lot of guys, it's not necessarily cancer control is their top priority. So I usually ask my patients, can you rank these three things for me? So I'll say, can you rank kind of cancer control, urinary continence, and erectile function, right? And some guys
Many guys will go the other
different.
way. Many guys will erectile function, urinary control, controlling the cancer. Yeah,
exactly.
I think that's
it's focal for us to phrase that, because a lot of patients come in and you have to kind of sit there and talk to them about what's their priority, right? So some guys are willing to trade a slightly higher risk of recurrence, or with the Gleason grade group 5 disease, I'm worried about, metastatic disease, right? So in that sense, I think the technology itself works for killing off tumor tissue and any tissue, prostate tissue. So question is, do they have micrometastatic disease that we don't know about? Does taking care of the primary fix that issue down the line? And that stuff I think is still, there's some more data that we need on that. But certainly that guy would worry me if he says, look, I'm absolutely going to do nothing else except for some sort of focal. I think I would offer him Tulsa with the strict caveat that he's going to be a very, we have to watch him very carefully for the next few years.
That is the perfect candidate. So this is that scenario. So look, I'm not doing anything else. I'm 52. I'm not doing anything else. And I'm willing to sign the dotted line. Promise not to sue you if things, I'm willing to sign the dotted line. That case, and I see a couple of these cases where Gleason 9 treated with focal, then you add on top of that aggressive lifestyle interventions, right? And these guys, you and I may have a hard time eating right all the time or exercising, right? We're too busy. I hope to think that's not my life, because I always say I practice what I preach, but let's just say, right? We're very busy. I don't got time for that. Gleason 9, prostate cancer, I'm ready. Give me the lifestyle prescription. I'm ready to do it. And a lot of data is indicating that there's a lot of anti-cancer, because people used to say, well, do this lifestyle stuff because I don't know if it does anything to your prostate cancer, but your overall life was great. And, you lower your risk of cardiovascular disease and you lower your cholesterol. There seems to be anti-cancer benefits here too. So that's the perfect person to kind of do both. And then again, we can track them and see how that works, right? Because I don't have the data either. If you don't have the data with Tulsa, I certainly don't have the data with guys, doing both. But I think that based on observation is a good approach. And the other thing is this: I had Eric Klein recently on the podcast, and he does a great job distinguishing between histology versus biology of a tumor. Right. So he's really focused on the biology of the tumor. How is it acting now? How is it behaving now? Not how can it potentially behave in the future from a Gleason perspective. And, the debate with Gleason 6s is it cancer? Is it not cancer? We shouldn't call it cancer. We should. There again, histology versus biology. Is this a Gleason 6? Not to go down a different rabbit hole here, but is this a Gleason 6 that histologically, active surveillance forever, but biologically maybe not, right? And there's a difference. That said, what's the perfect histological reading from a patient that you would be very comfortable with? What's the highest grade that one can go that you're saying, I'm comfortable in this scenario, all things considered?
Yeah, so I think any guy with intermediate risk disease, so we're looking at Gleason grade group 2 or 3+4 or Gleason grade group 3 or 4+3 disease. We've treated maybe 5% of our cohort with Gleason grade group 4. So that's probably kind of where I would say, all right, if you have pattern 5 disease within your biopsy, I'm probably very hesitant to treat you. I think intermediate risk disease is perfect for focal, whether it's HIFU, Tulsa, IRE, cryo. I still think, all focal has side effects, and you're essentially right back on surveillance. So I will most often try to talk my guys with low-grade disease, Gleason grade group 1 disease, to do surveillance. I think that's still the best thing to do. And a lot of times guys come in with, I think, almost a misconception that focals, you go in, you come out, no side effects, you're done with your cancer treatment.
It's a natural treatment, Dr. Meng. What are you talking about? It's a natural treatment. Don't I go to the health food store, get my Tulsa?
Right, exactly. Yeah, exactly. So I think I spend a lot of my time kind of counseling guys on that's not quite the right, maybe it's marketing out there, maybe it's, but there's certainly side effects of anything we do. And the best thing to avoid side effects was active surveillance for low risk guys.
So what are those side effects that you see most? I remember back in the HIFU days when it first started, you probably were, I want to say you even were was a resident at NYU
Yep.
when, Dr. Cianti was with us and doing a lot of HIFU with Dr. Lepore and everyone else. And I saw a lot of urinary strictures back then occurring. And it was like, well, okay, this is what happens. We know now that they've done better to prevent that with HIFU. What are the main symptoms or the main side effects, negative side effects that you get from Tulsa?
Yeah, so I think the main thing I see out of my patients is we really worsen their urgency frequency symptoms in the short term. Makes sense, right? Similar to anything else where you're causing inflammation of the prostate, swelling of the prostate. A lot of guys complain of kind of every hour they may have to pee for the first few weeks. When they have to pee, they really got to go, to the point where some guys will have leakage, urgency incontinence in the first few weeks. That does tend to slowly kind of get better over the next month or two. By 3 months, when I see most men, most of those symptoms are gone, but not for every guy. Some guys always have a little bit of increased urgency frequency. And that's something we're trying to pin down as to the extent of the ablation, the area of the ablation. Is it because we're closer to the bladder neck, closer to the apex? And the nice thing about this technology is it's done in the MRI machine. We have all that data, right? Any particular patient, if there's an issue with, I had a patient with a stricture, you brought up with HIFU. He had a membranous urethral stricture. We asked the company what happened. There's the company has a rep with every procedure, and they capture all this background data, and they do this super deep dive. Oh, there's actually a little bit extra energy got dumped past the apex of the prostate that wasn't seen. So that's kind of what, we're still early on in this procedure, right? There's only been probably 5,000 or 6,000 of these cases done in the US, in the world. In the US, it's certainly a lot less than that. We're the second highest volume center in the US right now. So we've done just a little bit over 180.
Okay.
Dr. Bush in Atlanta is a private practice radiologist, and he's done the most. I think he's in the probably 280, 300 range. But there's not a ton of experience with this. There's some of the European centers have had it longer than we have. So certainly Germany and Finland have had a little bit more experience than we have. But we're still learning about kind of all the different potential side effects. Like you mentioned, strictures or kind of urinary voiding issues. About, I think, 6% of the patients needed TURP. In the TAC trial, which led to FDA approval for this device. We've seen that about similar rates. 5 or 6% of guys will need a TURP to help them pee better.
So I would think that the Tulsa treatment will take care of that, where you don't need a TURP, right? Because it kind of does something similar. It opens up the urinary canal. But in some cases, they actually need a TURP after that, after Tulsa.
Yeah, I think some cases, some of those guys have more, fibrosis instead of kind of the tissue disappearing and having a nice wide channel. Some guys have fibrosis. Some guys have this interesting effect where I've noticed where if you treat half the prostate or quarter of the prostate, they almost have like a cavity or a diverticulum in the prostate, and you still have preserved urethral mucosa. So I think when they pee, because of having this cavity in the prostate where the cancer used to be, it affects their voiding dynamics, and opening up that mucosa seems to fix some of their urinary complaints.
So you're doing this, so you answered one of my questions that I typically have when I'm having a focal conversation, which is you can only do as good as your technology to see where you're targeting. Right. So you're doing it with is it similar to a 3T MRI? What kind of MRI are you utilizing while you're treating with Tulsa?
It's done in a 3T MRI. They basically come in, we get kind of fresh images, so they get T2 weighted sequence and get DWI sequence. So then we'll use that to plan our treatment. So because of it's still new technology, there's a longer wait list. Some guys will wait, 5-6 months to get in to see us. So it's a little bit rare for the tumors to progress, but occasionally patients will have a little bit more extensive tumor than when they got their MRI 6 months ago. So the fact that it's a live image right before treatment allows us to account for those small differences. We then do our planning on the images from 3T MRI, and then we run this called MR thermometry sequence. What it does is it basically looks at the whole prostate temperature, and it gives us a fresh temperature map. And we'd use that to plan our treatment. We use that to monitor treatment effect, prostate swelling. So I think that's what is the amount of feedback. I know I had Jim Wysock down to see some Tulsas, and he was saying the amount of feedback you get is really nice compared to some of the other technologies out there.
Now, we know that the prostate moves because we know that when you do a 3 MRI targeted biopsy, it's tricky because the prostate moves. What's the significance of that phenomenon happening while you're doing a Tulsa treatment where the prostate is moving? Can you miss it? Can you have this energy going in places where it shouldn't go?
Hmm. So that's already this is the worry, right? So we do a few things to try to combat that. So we give them a very extensive bowel prep, so they're on clears the day before. We give them, almost like a Miralax, almost like a colonoscopy prep to try to clean out the colon as best as we can. We give them glucagon to kind of decrease erectile motion. And the machine actually, if it detects too much motion, it will actually shut down the treatment and make you replan with fresh set of images. So that's one of those things we got to make sure your anesthesium is nicely paralyzed to try to minimize motion. And we do all these different things we do to try to minimize motion. But that's on the motion aspect. There's also swelling, right? Anytime you treat tissue, the tissue is going to swell. So we try to give things like steroids to try to decrease intraop swelling. And those are things that we can actually see with Tulsa probably better than some of the other technologies and account for. So that's one of the things I do like, that I think is a little bit nicer when you come to treatment. That gives you a little bit more precision of treatment.
What location? So it sounds like to me. So you're going through the urethra. So the transitional zone is the area, the zone or the area around the urethra. So though there's a low percentage of prostate cancer scenarios that are in the transitional zone, but if it is there, you can take care of that. How far out can you go? Is there a limit with the energy source that, if it's too far to, the capsule of the peripheral zone, then we'll probably do better with a HIFU than Tulsa. How far out can you go?
Yeah, so we actually all measure. So you can go about 3 centimeters. That's kind of what the company specifies. They just came out with this thermal boost module that allows you to go a few millimeters beyond 3 centimeters, but that's kind of where I do my cutoff because, like we talked about for swelling, if you have a lesion right at the 3 centimeter margin and it swells, all of a sudden you can't reach that whole tumor. So I'll try to make sure they're under the 3 centimeter mark. If for guys, so what that will mean is 6 centimeter prostate, right? So that gives you a pretty large prostate, 60, 70, 80 cc's. For guys that are larger than that, I'll put them on finasteride or dutasteride for a few months, shrink their prostate a little bit, kind of bring their tumors closer to where I need to treat to try to overcome some of those kind of technical challenges.
Is there a prostate that's too big for Tulsa? What's that number?
When they start to be about the 70, 80, cc range is when I start to get concerned. Everyone's prostate's different, right? Some guys have longer prostates, some guys have wider prostates. I always ask for an MRI, right? Because so I can actually do the measurements myself. But they've treated, I think in Europe for BPH, they've treated guys with 150 cc prostates because you're only treating transitions in, right? So depending on what you're treating, it's a little different.
Location, right? If it's closer to the transitional zone, then you can target that as opposed to it being further away.
Mm-hmm.
What if the tumor is close to some sensitive tissue, I don't know, close to the bladder, or when is it that we can reach it, but I'm not sure that we won't hit tissue that we don't want to hit? Mm-hmm. When is it that scenario?
Yeah, so I think a lot of times, bladder, neck, we're worried about. Apex, we're really worried about, by the neurovascular bundles, right? We try to nerve spare as best as we can. I think this is where having that tightly controlled margin helps you in those areas, right? I can say, okay, I'm not going to put an element that emits energy. So there's 10 elements that emit ultrasound energy. So it's over 5 centimeters, about 5 millimeters apart. So I can say I can treat a 5 centimeter prostate. So I can put my first element of energy away from the sphincter, right? But I can still treat the far apex. And we've treated certainly guys where tumors are almost touching the apex. And Dr. Bush talks about in his practice, he has guys that he's treated. And because of that tight temperature control and the closed loop feedback, I think you're able to reach those tumors a little bit better. I always counsel guys when we treat near the neurovascular bundles, it's going to have some effect, right? Even if we're, especially if their tumor is touching the, capsule there, we're probably going to have some effect on their erections, at least temporarily. We see that with almost all the technologies, right? Even if you're far from the nerves, IRE, Tulsa, HIFU, you're going to have some effect on your erections for the first few months.
What exactly is the rate of ED after a Tulsa treatment? As best as you know, I don't know if anything has been published yet.
Yeah, so for the TAC trial, I think they were looking, 80% of guys who are potent preserve potency. In our data, we're seeing similar rates, probably 70 to 80%. I think it varies depending on, where you're treating, tumor location. And then for guys with pre-existing ED, I think those numbers are hard to interpret because some of those guys, one, it's a little bit harder to get exactly their baseline erectile function, right? And two, I think those guys, sometimes a small perturbation to their existing erectile function is a drastic change that we don't expect.
Yeah, and my conversation with these men who are looking for guidance is very simple. ED before treatment is not going to get better after treatment. I don't care what it is. It probably will get worse. Your options in that, and there's no supplement over the counter in any gasoline or grocery store that will help you, and particularly in that scenario. You either need injections or an implant at that point. Is very clear cut, and yeah, that's pretty standard across the board. One of the things that I find interesting as I learn more about things like prostatectomies, right? Which of course I've never done one, but I've been in the OR a few times with some surgeons and kind of looked and observed, and I'm always very curious. Is this notion of, because every patient wants what? Hey, can you preserve the nerve? Hey. Xiaosong, I'm not kidding, right? So this is patient that I knew. So one of our surgeons did their surgery, and I go visit him at the hospital. He literally just got out of the operating room about 2 hours, and he's, I go to his recovery room, and he's asleep. I'm looking at his vitals and everything, and then he kind of, one eye open. He wakes up. And he looks at me, and the first question he asks is, "Did he spare the nerves?" Right. Did he spare the nerves? Right. So as we said in priorities, for some people, erectile function is number one and controlling the cancer is number 2 or 3. Right. But anyway, the point I want to make is that in this process and trying to preserve the nerves, how do we know that we're not leaving cancer behind? Hey, friends, please help me welcome one of our special sponsors, Focal One. When you're trying to choose and be part of the shared decision-making of, what's the best focal therapy for me, assuming that focal therapy is the right approach for you and your prostate situation, ask them about Focal One. Focal One is the first and only robotic platform for precise focal ablation of prostate tissue using high-intensity focused ultrasound, or HIFU. This minimally invasive technology offers prostate cancer patients a game-changing treatment with no surgery, cutting, or radiation. With unmatched precision, real-time imaging, and advanced software for MRI fusion, Focal One ensures faster, safer, and more effective treatment, sparing healthy tissue and minimizing side effects. Treat the suspicious lesion in your prostate and leave everything else alone. Next time you visit your urologist and you're talking about your prostate cancer, if that's what you have, ask them if you are, number one, a candidate for focal therapy. Number two, if they use HIFU, ask them, are they using Focal One? To learn more about Focal One, please look at the link below in the show notes. By trying to do something good, maybe there's some cancer there. So that's always the dilemma, I think, as it relates to prostatectomy. Similar concerns, I'm sure, that if you don't hit the area that, there's nerves there, but we got to hit this area. If not, there's cancer there. With Tulsa, I'm sure there's a similar concern, no?
Yeah, for sure. So, for guys who have, a little bit of extra prostatic extension by the nerves, I'll tell them ahead of time we're going to impact those nerves. Right? We'll do our best to nerve spare as best as we can. But I agree, if you undertreat that area, I'm worried about margins. I'm worried about cancer, leaving a rim of cancer there. Some guys say, hey, look, I'm willing to take that risk. I can always come back and get another treatment if need be. But I try to tell them if we're going to be in there treating, we should try to maximize our treatment efficacy for cancer. Right? That's kind of the purpose of what we're doing for in here. And the whole nerve sparing thing is actually interesting. Right? We think about those kind of two bundles that sit on the side of the prostate. But, when they look at actually studies of the nerve distribution, it's certainly not all in those bundles. I think maybe 50, 60% in the bundles. There's some kind of spread throughout the surface of the prostate. There may even be differences in kind of distribution. Maybe one side is 70-30 or 20-80. So you really don't know whether doing a unilateral nerve spring is completely going to preserve a guy's erections. We do our best, I think, we try to maximize that, but I think that's always, I don't know if we're going to fix that yet or any time in the near future, but I think that would be something, if we could improve erections, that would be the gold standard for prostate cancer care.
Yeah, that would be a game changer for sure. Having some ED expert in the operating room with the surgeon and say, right at the same time, right? And kind of doing things so that you preserve as much erectile function as possible. in recurrent situations, right? So whether TULSA was the primary treatment or something else was the primary treatment, let's say HIFU or anything else, or any other treatment was the primary treatment, where the prostate is still intact, can TULSA be what they call salvage treatment for prostate cancer?
Yeah, so for our cohort, we've treated, I think, 25 guys in the Salvage setting. I think about 60% of them are post-radiation failures, and we'll talk about that later. I think that's another great indication for focal. And then 40% of guys who've had other things. They've had FLA, they've had HIFU, they've had TULSA before and failed. So those are kind of, in the Salvage setting, I do think you're able to retreat guys who have recurrences. And often, guys, I've noticed, patients who've had focal before want focal again, right? Because they've been told certainly, I think surgery is doable after focal, but it's a little bit harder than it is in a kind of a naive prostate. Are you able to, is this lawnmower presenting an issue or no? Okay.
No, not at all, actually.
Okay.
We
good.
have good noise reduction cancellation. That's why I use Riverside. So go right ahead.
All right, perfect. So no, I think TULSA is a good salvage option because oftentimes the gland's a little bit misshapen. For cryo, you're trying to rely on kind of anatomic landmarks, or you're trying to use fusion. And fusion is sometimes a little bit less reliable when you have a misshapen gland. So certainly I do treat guys with focal failures and things like that.
From focal failures and with TULSA. They get TULSA as their primary treatment as a recurrence. The patient, can they get a secondary TULSA treatment? I think that's been offered in some patients. And are they a candidate? You mentioned it a little bit a while ago. Are they a candidate for surgery? How messy is the surgery? Let's say relative to radiation therapy, which is very messy after radiation. So, is a secondary TULSA treatment a viable option? And probably you're going to say it depends, and of course, that's the right answer. But you can go deep into that. And secondarily, how is a prostatectomy a good option, a good surgical option, and how messy is that after TULSA?
Yeah, so when we looked at our data for guys who failed TULSA for primary cancer, about 6% of guys needed something else done or did something else at the 1 year mark. So a few of those guys went for repeat TULSA. So those failures were guys we treated more focally. We looked at them again at 1 year and found cancer outside of where we treated. So then we went back and said, okay, now we're going to do whole gland TULSA. We're just going to cover the rest of your prostate to try to eliminate any out-of-field recurrences. I think 3 guys went for surgery. One was from the initial TAC trial because they weren't allowed to undergo repeat TULSA. And then 2 guys were young. One guy was like 46. He just said, all right, I failed it. I'm just going to get my prostate out. So we have limited data on salvage prostatectomies after TULSA, but on the patients who've had it, it's been okay. Certainly the plane near the side that was ablated is a little bit worse, but this other side that wasn't touched is almost virginal, right? So I think unlike HIFU, where you have energy going through that kind of, perirectal area between the prostate and the rectum, because you're going from inside out, I think some of those planes may be slightly better preserved. Certainly, I think near whole gland TULSA is going to be a little bit more challenging, but as we get more and more of that data, we'll be happy to kind of share it.
I'm glad you mentioned that. So patient has a tumor somewhere in the anterior zone, for example, and you just treating, how far out from that tumor area are you treating to just kind of ensure that, are you totally banking on your imaging from the MRI and say, well, that's the only, this tumor here, and you go out how far beyond that particular tumor to treat? Because you just mentioned that, oh, well, in some cases we have to do full gland TULSA. So expand on that a little bit. So one tumor, you can hit it, just that tumor. How far do you go? And when do you think that you have to treat the whole gland with TULSA?
Yeah, so I think there's some good data showing if you use 5 millimeter margins versus 10 millimeter margins, you're going to have higher rates of recurrence. So we try to shoot for at least a centimeter margin around your tumor, which often, comes down to be at least an extended quadrant or hemiablation, right? I think truly doing a very focal, just tumor specific with very tight margins, I think a lot of people are moving away from that concept in focal. And with TULSA, because you can reach the whole prostate as need be, you're essentially your pro spins 360. You can do anywhere from a quadrant to hemi to a whole gland. And they don't take that much longer because of the way the technology works. So for guys who prioritize, cancer control, we try to treat as much prostate as we can. There's actually a randomized trial that's being ongoing, and UT is one of the sites. It's called the Captain Trial, and it's a randomized trial comparing surgery to TULSA. And it's a good trial. It's a little bit hard to accrue for sometimes because some guys say, look, I want to come in, I just want TULSA. And because it's a randomized trial where they can get randomized to surgery or TULSA, they have to be okay with that. So,
wow. And this is for low intermediate risk patients?
This is for intermediate risk disease. So 3+4, 4+3.
Okay.
And I think they're about halfway accrued for the trial. I think they're going for about a little over 200 patients.
Wow, you get randomized. Okay. Nope, you're the surgery guy. No, you're the TULSA. I mean, that's
and the way I tell patients that we don't know, right? We don't know if this is truly better or not. The only way we can really figure this out is a randomized fashion, and we're looking at 1 year urgent, urinary control and sexual function, and 3 year cancer control. And this is really the only true way to answer this question as best as we can. Right? And some
how
of these
long
guys,
will you follow them for? Because 5 years, 10 years, and then that you get your best data is probably after 5 years, perhaps.
Yeah. So the two endpoints are 1 year functional outcomes, 3 year cancer control, and then I think they got followed up to 10 years out. Yeah. But that's kind of a little bit, those are secondary; those are not primary endpoints.
Right. Fascinating. No urinary continence issues with after TULSA?
There's some. I'd probably put the risk at somewhere, probably in the TAC trial was 97% guys were continent. I think continence is actually an interesting idea because we've been trying to nail this down recently with our guys.
Yeah, what does continence mean? How do you define continence? The surgeons, the surgical group, is like, one dry pad. Well, before surgery, I didn't need any pads. So how can that be dry? And that's on the good, that's on the good list. So when they come out with studies as it relates to TULSA and incontinence, is dry really dry?
Right. Yeah, so I think they were saying it was something like 90, 92 or 95% of guys had no pads, right? 97% were one pad or less. So I quote guys somewhere in the 1% to 2% range, right? But lately, what I've been feeling is we actually sent out a whole set of patient surveys for TULSA to kind of quantify how many guys think they're incontinent and what are the things that they call incontinence. So post-void dribbling is a big one, where a lot of guys have a little bit of extra post-void dribbling. And they term that incontinence. And as surgeons, we say, that's not incontinence, that's post-void dribbling. But to the patient, hey, I'm still leaking, right? So those are kind of the things that we have to go in and set expectations a little bit of what that is. And it's one of the things that we don't think about that I think we need to pay more attention to, because guys coming for focal have sometimes a higher expectation of preserving those functional outcomes.
It's what do you mean, Dr. Meng? It's a natural treatment. Yeah. Oh, there are side effects potentially from this? Yeah, right, exactly. And it's very similar. So also you have to compare, it's very similar to men with ED prior to. Men, as they age, they have some dribbling issues under normal circumstances. Some of them have incontinence issues under normal circumstances. So I think that if you're having any type of incontinence or dribbling issues prior to focal treatment like TULSA, it's not going to get better like ED. It's not going to get better from after treatment.
I think for the most part, there's maybe a smaller number of guys with urgency incontinence due to kind of BPH and things like that. Sometimes we maybe help their flow, similar to doing a TURP on the guys, where it may improve some of those symptoms down the line. But I agree. I think if you already have bad bladder overactivity, we're probably not fixing that with this.
How many TULSA practitioners in the country? I don't know one in New York. So how many, first of all, if you know any in New York, let me know. But how many are there in the country, considering that this is still relatively new?
Yeah, so I mean, I think Profound's website has all the different places that do it. I do know.
What's the name of the website?
Profound. So Profound Medical is a company that developed TULSA. It actually came out of Canada from kind of Laurie Klotz and some of the people out there who developed the technology. So, here in the U.S., so Hopkins, I think, is started treating patients. Stanford's been treating patients.
Dr. George, Arvin George, started treating. He seems to do quite a few, right, of focal therapies. So focal therapy practitioners, I've noticed, do 2 or 3. They don't just do one. Is that correct, more or less? You have to, right.
So we do TULSA, we do IRE, and I think we'll probably bring on HIFU, because for guys who come for focal, everyone has different anatomy, right? So one of the things with TULSA is if you have calcium deposits within the prostate, And that's one of the things we screen for as part of the workup. If it happens to be between your tumor and your urethra, you're not a good Tulsa candidate, right? Because the calcifications heat up or the bounces ultrasound waves off. But if you're not a candidate for Tulsa, you could be a candidate for IRE, right? I could put in transperineal probes and still treat your tumor. Or if you have periurethral calcifications and a tumor in the peripheral zone, I can still treat you with HIFU, right? So I think most places will need to have multiple different energies to accommodate all the different kind of anatomic variations and tumor locations that men come in with.
Right. Makes sense. Dr. Xiaosong Meng, man, thank you so much. I really appreciate it. This has been, I say over and over again, maybe the audience is actually tired of hearing this. If I would have known that podcasting is so much fun and I get to talk to, one of the top leaders in the different areas of urology and men's health, I would have done it, 10 years ago. It is likely impossible. I just had Eric Klein as a Dr. Eric Klein. I mean, I just love talking to him, and he's just a wealth of knowledge and, the things that he's doing now. Arvin George, amazing to talk to him about, focal, talking to you about Tulsa. The truth is that we see each other at meetings, and you are one of our alumni at NYU. And every now and then, there's no way we're going to have an hour conversation or 40-minute conversation on anything because it's just we don't have the time. So, and this is one of the reasons why I love doing this. So thank you so much for taking time out to do this, and congratulations on the newborn of your child.
I appreciate that. Thank you so much, Dr. Geo. It's a pleasure chatting with you. I think this is a great service. I think a lot of guys want information. They want good, high quality information, right? There's a lot of information out there for prostate cancer, whether it's true or not on the internet. And I think
there's a lot of false information on the internet, actually, and a lot of bad information. So yeah, we definitely are trying to have the leaders in place in all things prostate cancer, natural, conventional, the different areas of conventional medical treatments that I think are helpful from experts like you. So thank you so much. How can people find you if they want to find you or your practice?
Yeah, so I'm on the UT Southwestern website. They can just look for my name and I'll pop up. I'm on the Profound website for Tulsa. I think I'm on the IRE website for focal as well. But yeah, they can look me up at UT Southwestern. We're happy to, see patients where I see a lot of second, third opinions. I think almost 20% of my practice is out of state. So I see guys as far as Hawaii to Colorado to California. I see them from a lot of different places, and I'm happy to see everyone and try to at least chat with them.
Good. Well, thank you so much. Thank you, everyone, for listening. This yet another just amazing episode on prostate cancer, yet another treatment, Tulsa. And you've asked for it, and here it is. We have one of the foremost experts on the subject. Thank you for listening. If prostate cancer is one of your concerns, you know the deal. Make it an opportunity. Make it an opportunity for you to live your best life after this diagnosis and do all the things that you should be doing, because lifestyle medicine is indeed medicine. Thank you for listening, and I will talk to you next time. Much love. Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.